For this next presentation, we'll talk a little bit about the thigh. That has to do with the compartments, and as anterior, medial, posterior. We're going to talk a little bit about function of the muscles in the thigh, the actions that they have from the hip down to the knee. We're going to mention a little bit about referred pain, but also we're going to talk about situations about the knee specifically. So here the important thing is talking about an AP, and lateral view of the knee. It's marked, so you can see it's a left knee. Here's the mark in your radiograph, as you probably will always see it. But also from the anatomy standpoint, the fibula is lateral to the tibia, so that's a left knee because of that. You can see outlined the patella. So the important features here is the shaft, the diaphysis of the tibia and fibula. You're going to have the head of the fibula, which always is posterior to the tibia on that lateral aspect. You're going to have a couple of pointy stuff there. They're called the spines of the tibia, or the tibial, spinal tibia eminence. And you're going to have your medial and your lateral condyle of the femur. Remember that there are two structures that I said that could be important. Medially, you're going to have at this level the insertion of the pes anserina, and also you're going to have just about on top of the medial condyle where the shaft into the metaphyseal area reaches the condyle. That's where the adductor tubercle is going to be placed, and the adductor longus, part of the major adductor muscle, is going to be attached there. There's another structure, the adductor canal, or Hunter's canal, we're going to be talking about in a little while. On the lateral aspect, you have your patella profile at the patellofemoral joint. That's one of the compartments of the knee. The other two compartments of the knee is the medial compartment and the lateral compartment. So the patellofemoral compartment is one true, if you're going to call it, area, and it serves as a gliding motion. The patella is the largest sesamoid bone in the body, and it's being covered by the quadricep tendon, two retinacula, that's from the medial vastus medialis and the lateral vastus lateralis, that's covering the patella, and ends up with a patellar tendon and attaches in the anterior tibial tuberosity, a little bit overexposed here, but this is about the level of the anterior tibial tuberosity where the patellar tendon goes. Some textbooks call it about the patellar ligament, but it's not a ligament per se, because any ligament is going to be attached for motion as this one is. So this is a true tendon, because it also offers an apophysis, because an apophysis is any site that the bone has cartilage as a center of ossification for the tibia and the patella, because both of them are centers of ossification and they hold this tendon. So, and it serves as motion. Some structures that are important as patellofemoral is that the patella has some surfaces and a ridge. The most important thing is that the odd facet, and the odd facet helps with maximal flexion of that knee to cover over the medial condyle. The other important thing is that there's a distal end and a proximal end or aspect of the patella. Let's move on to the other one. Different contact areas depending on the amount of flexion of the knee. So what amount of, on the most superior or proximal area of the patella versus the lower end of the patella, having contact with the femur at those specific degrees of flexion. The important thing of these two images are called sunrise views. And the sunrise view is where the patella is coming on top of the femur, and this is the patellar tract. This is between the femoral condyles. This is the lateral side. This is where the lateral retinaculum is. This is the medial side. So sometimes you're going to have, if we follow the next one, besides the space that you might have, you might find that sometimes the patella moves or shifts laterally. And that's because two reasons mainly. One, because you have a very strong and shortened lateral retinaculum, very weak vastus medialis, and also you can have some sort of underdevelopment of that lateral condyle. So the following notice about a Q angle. Q angle is not by radiograph. This is important. When you go to your internship, you might find some people that talk about Q angle, and if they ask you, do you have your X-ray? Q angle has to do with clinical performance or clinical assessment. And the way is to understand more or less from the superior iliac spine, and probably I could have one of a model here to show you the Q angle. So Q angle is, can you touch your superior iliac spine? So she touches her superior iliac spine into the center of the patella. So an imaginary line is going to be drawn from this aspect on both sides if you wish to. And that's one line. The other line goes directly from the tibial tuberosity into the center of the patella. So the center of the patella is going to serve for 2 points of reference. One, superior, coming from the superior iliac spine, and the other from the tibial tuberosity. So those 2 lines are connected, and there should be an angle. Thank you. So from that angle, coming as or following the shaft of the femur, and from that tibial tuberosity to the center of the patella, those 2 lines are going to form this Q angle. What you want to have is less than 20 degrees. If you have more than 20 degrees, it means that most likely you might have a valgus. You have an opening of that angle midline. So the normal is, like it says there, 12 to 15, but some authors may go a little bit higher. More in females is larger, this Q angle, than males. So the way to remember this, as it says there, Q angle over 20, you think about genovalgus or genovalgum as the first diagnosis, and other possible situations having femoral anteversion. So anytime you have a femoral anteversion that's increased, how can you determine that? Basically, those people that can sit in the W position, they have higher femoral anteversion. Children have higher femoral anteversion, probably to the degrees of 40 to 30, something like that. Adults will have probably not more than 20 degrees of femoral anteversion. But at any rate, the other 2 concepts is that anything that closes the angle midline, that's called varus. So genovarus, that's for the knees. But you can have coxa varus, which means that the hip has a varus, less than 125, 130 degrees. Opening the angle midline is going to be valgus. Same with the elbow. You have something that closes the angle is varus. Something that opens the angle, a cubitus valgus, that's going to be a higher degree in that angle. Let's follow the other. Next. So things to remember here. Patellofemoral dysfunction, or the clinical side or condition is called patellofemoral pain syndrome, has to do a lot with possibility of higher Q angle, some tightness of the ITB, the iliotibial band. Typically, if you have something like this, the patella will shift a little bit to the lateral, bringing that lateral retinaculum just a little tighter, which means also that there's weakness of this vastus medialis, oblique. So the vastus medialis is weak. there's a tightness of this with the lateral retinaculum being short, so that the compressive forces on that lateral compartment, or the condylopatellar or the patellofemoral site, is going to be with higher chances of friction, and during flexion, more wearing of that cartilage. So chondromalacia is typically the clinical condition where the softening of the cartilage comes by. Let's follow the next one. So some important structures about the knees, those ligaments. So they're going to be extra-articular, some superficial structures, and some intra-articular or deep structures. The extra-articular are going to be, as we already called or talked about, the quadriceps tendon and the patellar. Again, it says ligament, you can use it, ligament. By definition, it won't be a ligament, it's a tendon. The patellar tendon, patellar retinaculum, you have a medial and you have a lateral, and that's the expansion of the quadriceps tendon over the patella. So there are fibrous expansion, and this is reinforcement of this structure. The medial patella retinaculum is from the medial vastus medialis, and the lateral retinaculum is from the vasolaterales and ITB. The other important things are the medial collateral ligament and the lateral collateral ligament. The medial is from the tibia, goes from the medial epicondyle of femur to medial tibial condyle, and attaches the medial meniscus and the lateral fibular collateral ligament. And the lateral collateral fibular ligament attaches directly into the part of the lateral tibia, even into the fibula. The oblique popliteal ligament is basically for the capsule, and the arcuate popliteal ligament. Probably just to show how the lateral collateral ligament, some fibers will go into the tibia, but most of them are going to be directly into the fibular head. So the lateral collateral goes into the fibular head. The medial collateral ligament reaches the tibia and part of the medial meniscus. A little bit difficult to see this one, but the oblique popliteal ligament, as you can see it there, it's basically deeper than the head of the gastrocnemius and the insertion, and part and coming lateral from the semimembranosus insertion. Let's follow the next one. The arcuate ligament is a structure, a very strong fibrous band that is going to be part of the posterior lateral aspect of the knee. The other important structure here to talk about is the popliteus tendon that crosses, and this is a reference mark, a landmark when you're doing arthroscopy of the knee, to know that on the lateral side there's going to be a foramen or a hole where you can see passage of the popliteal tendon at that level, on the lateral aspect posteriorly. The lateral collateral ligament, talking about specific structures, comes from the lateral femoral condyle directly over the femoral head, the fibular head. Some fibers may attach, also reach part of the tibia anteriorly. As you can see it here, some other fibers behind it crosses posteriorly. The other important thing is that when you have extension and flexion of the knee, those fibers will hold basically the same amount of distraction of those fibers. They don't really collapse or shorten in any way, as probably you might see here for the patellar tendon, that an extension, they have one length, but when they flex, they stretch out much more. Just a representation of how the lateral collateral ligament from the femur, the condyle, lateral femur to the fibular head, that's where it attaches. Representation in a cadaver sample at the lateral collateral ligament, the fibular head into the femoral condyle, the popliteal or popliteus tendon, that's lateral posterior, and the lateral meniscus being shown here. Also, the other relationship important is the tendon of the gastrocnemius, the lateral head that attaches into the posterior aspect of the femoral condyles. The medial, on the other hand, as you recall, the lateral being quite narrow, not expanding. The medial one goes a little bit more into being wider, and remember that its origin is in the medial epicondyle and reaches down over the medial meniscus, ending up in the proximal tibia. And it's a broad ligament, goes from midline about halfway posteriorly, attaching to the medial meniscus, and offers a band a little distal. So this is a major stabilizer of the knee. Although the lateral is also very important for stabilization, the medial side offers just a little bit more of need for a different motion of rotation, basically. So anytime there's an extension of the knee, there holds some fibers will hold some stretching, some length, but when it flexes, part of them will shorten in some way. Two bands, if you're going to call it as a Y or just a continuation, once it attaches to the medial meniscus coming distal into the tibia. As you can see here, the medial collateral ligament does go posterior and ends up on top where the pes anserinus is. Most likely this might be part of the semitendinosus and gracilis muscle where the medial collateral ligament reaches distally. So the intra-articular or deep structures are called for the ACL, the PCL. The ACL, the easiest way to understand it, goes from medial to lateral and goes from anterior to posterior. So in a model, the origin is going to be at the tibial spine. So the tibial spines that are here, medially, that's where the anterior cruciate ligament will insert, crosses, that's why it's called cruciate, because it crosses and attaches to the lateral condyle, femoral condyle. The posterior is lateral, and it runs medially. Posteriorly, not so posterior, but a little bit aligned, but that's posterior also to the anterior cruciate ligament. And those are specific for rotation and also control anterior-posterior motion. The other two important structures are the meniscus, the medial and lateral. The coronary ligaments are those that extend from the hip, the knee joint capsule and attach to both of the medial and lateral menisci. The transverse ligament holds both of the meniscus in front and in back, and the posterior meniscofemoral ligament as being meniscofemoral ligament as being anterior and posterior. Those transverse ligaments, although they say it might be absent, the coronary, transverse, and posterior anterior meniscofemoral ligament, they're really true structures. So the coronary ligaments run at the base of the tibia plateau and going and attaching both of the meniscus. At that level, that's where those coronary ligaments are going to be. Now the transverse ligaments, let's move forward. The transverse ligaments are going to hold both of the horns, anterior and posterior, at that level. So the meniscofemoral ligaments are important to have their presence. And the coronary ligaments, you won't be able to see them completely on the anterior aspect, but here they're attaching from the tibia going into the hip, the knee joint, and attaching directly into both of the medial and lateral meniscus. So here the important thing is, remember I said on the lateral side, the fibula, that's where the tendon of the popliteus muscle, you're going to be able to see it. You're going to have the posterior cruciate ligament that is extra articular in the most posterior aspect, and the anterior cruciate ligament goes from medial to lateral. So it's important to use your hands in some way to say, you're going to talk about your right knee, your left hand might be a little bit inclined in such a way that you can say from anterior medial goes to posterior proximal, like this, and the posterior ligament goes exactly a little bit less oblique, but more on the vertical perspective. Things that might happen. With the ACL and PCL, you're going to have later on watching and knowing those signs as a drawer sign, lag of the knee, is going to be the anterior medial and posterior lateral band. The anterior medial band, how it's going to tight in flexion of the knee and lax with extension. The posterior lateral band is going to be opposite. Tightens with the knee in extension and laxes with flexion. And you can do the same movement. So you take one ligament of them and try to do those motions to recall how they would be tightened or being relaxed. The meniscal tear is important to understand that they might be hurt, they be damaged, but the most important thing is that there's some areas where they don't have blood supply, they don't have nerves. So if you have a chance to see part of the meniscus in a given way, you might have something like this shape, and think about this part connected to the bone. This received blood supply. This one, and that's about 2/5. They have blood supply. But the inner side, because there's the other meniscus is about here, this doesn't have blood supply. So what it means as a vascular is that this area won't be able to repair as much. So it's important to see that the free part, this is insertion to the tibia, this is free, this is not inserted. This part, the free part, doesn't have vascular supply or nerve endings. Just the part where it attaches, that's where it's going to be able to be repaired in some way. So the other thing important for you to read and remember and know is that meniscus are not removed anymore. It was a practice of the past. Now it's either repaired in some way by sutures, or they just remove part of it considering the type of tear they might have. In ACL, the tears that you might have, either partial or complete, is going to be described as or defined for treatment as what is the person's age, the patient's physical activity needed to make a best decision for that. People can live without an ACL, and the chances of having osteoarthrosis is going to be directly related with the amount of physical activity that they have. I just mentioned anterior drawer test, also Lachman's or pivot shift are some tests specific for the ACL or PCL for this matter. So as you can see in this intricate sequence, the ACL, medial to lateral. The ACL is anterior, PCL is posterior. ACL is medial to lateral, anterior to posterior. If you recall those four directions, PCL has to be the opposite, as simple as that. So same thing with what you're going to be looking at as having stability. I think that's about here. So the other important thing here is the type of motion that's going to be happening. If you see this as what's going on when there's a flexion of the knee, the ACL gets stretched. When you're talking about moving an external rotation, ACL is being stretched. So how can you injure this structure is precisely, if you recall in football, the clipping type of motion, there's extreme flexion and external rotation. So by doing flexion and external rotation, chances are to injure this other type of structure. Same with internal rotation. So the ACL is going to be considered in any of those range of motions.
Posterior cruciate ligament can be torn. It's not as common or often as the anterior, but it might happen. Both of the meniscofemoral ligaments are considered sometimes to be not consistent in all patients, but really both of them are present there, and there's the following, and you can see them here as the anterior posterior meniscofemoral. That's where they attach, and they're posterior stabilizers, and also for, as you can see, the shape of them, they hold the posterior horns of the meniscus, but also for internal and external rotation, they have a capacity of sending a message just to allow a certain degree of motion. Meniscus are going to be structures made of fibrocartilaginous tissue. They have a wedge shape, being the most broader side attached to the tibia. The most narrow side or shape is going to be on the free side. Remember, 2/5 are going to be related with vascular supply and nerve endings. 3/5 are free. They can float. They can be picked up, and they work like shock absorbers. But those 3/5 of the meniscus do not have nerve endings or do not have blood supply directly to them. Just a quick view of the medial side, where the medial, the ACL, the medial meniscus, and the lateral meniscus. So from medial to lateral, that ACL is going to be placed, located. The posterior cruciate, all looking at an axial or transversal, you can see that it's placed posterior to that anterior, and the shape of it, how it looks, comes from a little bit more lateral into medial. The shape of the medial meniscus is more open as a C. This is a little closer, like a ring. So the medial side is always a little bit open. The lateral side is a little bit closed in this matter. Important to understand that both of the meniscus, both of them will have capsule. This is a difficult slide, but capsule is holding both of the menisci. Coronary ligaments are going to be holding both of them too. Horns as anterior and posterior, and the transverse ligaments. So what holds both of the meniscus? We'll start probably between them, and that's going to be the coronary ligaments. Also, the transverse ligaments are going to be held. Horns and capsule are the other two structures. Now, specific for the medial side is going to be, besides those two structures. The medial collateral ligament that we already talked about being a broader one and holds attachment, even reaching down to the tibia, to the medial meniscus, and also part of the semimembranosus muscle or tendon going an expansion, going posterior, medial to the knee. That's for the medial meniscus. Now for the lateral meniscus, remember that I mentioned a couple of times the popliteus tendon, probably something like this structure that you might see here. And you're also going to have part of the meniscofemoral ligament. The meniscofemoral ligament comes more for the lateral side than for the medial side. So the medial meniscus, as seen here, is going to be more open, like a C shape. It's going to have an anterior horn, the body, and the posterior horn. You're going to have the transverse ligament, and you're going to have all the attachment, the radiate ligament. Here's more of a ring shape, more closed. Same thing with the coronary, the transverse ligaments, and you're also going to have for the posterior, anterior horns and the body. Also, you're going to have the meniscofemoral ligament, as you can see it probably from here in this cut. So, like I said, it works like a shock absorber. So they adapt bones of the femur and the tibia, and for specific movements as flexion, extension, those meniscus will change its shape a little bit on the gliding motion. So rotation and flexion are going to adapt, and they're going to change the curvature to each other. By doing this, the synovial fluid that's within the joint is going to expand. They're going to distribute a little bit more efficiently, that synovial fluid. This is an injury that it was very common in football players by clipping. That's why it's so penalized, and they don't do that. They don't allow, never, that type of injury or type of movement because the chances of injury of the type of play is going to cause damage. And O'Donoghue in Oklahoma, O'Donoghue brought this as a concept, and typically what they saw is the medial collateral ligament was torn, not necessarily here, but I mean it's a damage of the medial collateral ligament. The ACL was torn, and also they have part of the meniscus torn, and the deeper fibers of that medial collateral ligament. So the triad of O'Donoghue was considered these three structures. And just to take advantage of looking at this image of the meniscus, this is a bucket handle tear, because it resembles like the handle of a bucket that you hold it, that's how it tears. Can buckle, can give you some sort of obstruction in the blockage of movement. So different types of fractures or tears along the meniscus. The bucket handle there seen in the middle on the left side, that's probably one of the most common type of injuries. But they can be a bulge from its origin, so the whole thing can flip over, not necessarily having a tear here, but a bulging from there. There can be a torn horn or the body as a radial. There's no, this is called transverse. Transverse and radial fracture would be the same, would be a synonym, it would be the same type of injury. On the right side, this is a T1 MRI, and it shows that the shape, triangular shape of the meniscus with difference in the intensity of the signal, where you can see clearly that there's a tear over the substance of the meniscus. Bursa, as in every single part of your body, you're going to have several bursas. Probably the most important ones, considering you might have symptoms, would be the prepatellar, that you can really feel it, very simple. The suprapatellar, where the quadricep muscle is, and you're going to have two infrapatellar as superficial and deep. And that's anteriorly. Posteriorly, you're going to have directly related with either conjoint tendons, as the pes anserinus, or specific muscles, as the gastro, the semimembranosus, and the popliteus. So bursa is related with a chance of this structure be placed under friction, some rubbing, a little bit of action in that area, and it needs a little bit more of support or more probably like a cushion, so it won't be damaged in any way. So just a reminder to go over in your slides where the different sites of the bursas are located at the deep, infrapatellar, superficial infrapatellar, infra because it's underneath the patella, but you have this one, the prepatellar bursa, that's very common, and the suprapatellar bursa. Typically, anytime you have a injury, some acute internal derangements of the knee with bleeding, you're going to have that suprapatellar bursa very swollen, filled with fluid. Another version of this, red thing, that's where it's supposed to be fluid, in this case blood in that area because of the color, but that's the site where you're going to find those bursas, or bursae. The one that's directly related with the pes and sarina, remember the most superficial one is going to be, or the superior one is going to be the sartorius. Then you're going to have two as the semitendinosus and the gracilis, and that's a conjoint tendon. Blood supply, they're going to come directly from the popliteal artery, which is a common perineal artery, and the popliteal artery, the popliteal artery is going to be coming directly from the femoral artery, and they're going to bring or give the genicular arteries. They're two inferior, two superior, one medial, one lateral for each side. So the important thing is that the femoral artery goes down, and that femoral artery is going to continue as a popliteal artery. Sensation or innervation should be really considered as motor from the obturator, the femoral, both are the specific from the lumbar plexus as the anterior and posterior division, and then you're going to have the common fibular or perineal, also that's coming from the sciatic nerve as a tibial. Those are the two divisions of the sciatic nerve.